Boom, boom. You can see their nice photos right there. Okay, we have Dr. Chris Nash here, resident physician at Massachusetts General and Brigham and Women's Hospital. And we also have Danielle Ryder. She's an MD candidate at Wake Forest Baptist Health. Are you with me, people? Are you there?
I'm here.
Yep, we're here.
Okay, wow, they are there. Thank you so much for joining, people. I love it. You're coming in loud and clear. Okay, so first things first, thank you so much for joining. I just want to hear just generally, and Danielle, we can start with you. What have you been seeing? What were you seeing, and what have you been seeing? What was your general kind of boots on the ground feel of what's been going on with all this?
Yeah, totally. So just to provide some kind of background, I'm a third-year medical student at Wake, and how medical school works is the first 2 years are didactic, so you're in a classroom in a lecture hall learning from books, and then the second 2 years are in the hospital, getting firsthand clinical experience and working alongside physicians. So I'm in my third year, and I had just started my pediatrics rotation when this all kind of started. I began in infectious diseases, which is not where you want to be when a pandemic breaks out, but it was a good experience. So I can tell you that on March 4th, when I was going into the pediatric ED to see a patient, I went to gown up outside of a patient's room, and the cart outside of the room was completely empty. There were no gloves, there were no gowns, there were no masks. So I was like, okay, that's strange. And I walked down the hall to try a different cart, and same thing. So I ended up going to the nurse's station and asking the nurse, like, where's all the protective equipment? And she said that families had been taking them because they were so panicked by the rising COVID situation that they'd been stealing the masks and there weren't enough for providers. So the nurse actually only had one box of masks behind the nursing station, and that was what we were working with. So that was the situation in March.
Wow, and that's when it became real for you.
Totally.
Right on. Okay, Chris, Dr. Chris Nash, what do you got for us? What's been your take with working with all this in the hospitals?
So I work in the emergency department, and that it should be said right now, only speaking just in my own experiences. It's not speaking for Mass General for the Brigham, but I'll tell you a little bit about what it's been like.
Absolutely.
I think what I have been seeing is there was this eerie calm as for the first maybe around a month ago, before it really started picking up in Boston, what we were seeing was the emergency departments were eerily calm and people weren't coming. And one thing to know as a background in the ER is that we'll take care of anybody who comes every time. Nobody gets turned away. We see every patient if they're willing to wait and stay for us.
Right.
Which means that a lot of people come for things that aren't necessarily emergencies. That could be a sprained ankle, it could be whatever else. And granted, people aren't outside, so people aren't getting in car accidents as much, and people aren't rolling their ankles as much anymore. But when all of that volume dropped, as people are trying their best not to come to a place where they're much more at risk than where they are at home, it became like kind of a ghost town, which in some ways was really nice, but was really eerie. And I've been working in ERs for years, and that was a big change. And I think it makes your hairs rise up on the back of your neck. Within the last 2.5 or so weeks, it started getting sick, meaning we're starting to get to the point where we're starting to have peak numbers of cases where patients come in breathing extremely fast, can't catch a breath, can't even talk, and we need to intubate. And I myself have intubated 3 patients for this.
And can you talk about what that means exactly? Because I wasn't familiar with it until you told me about it earlier. So what does that process look like, and what does that mean?
Sure. So the idea is if we think patients are not breathing well enough on their own, then we put them on a ventilator. And a ventilator is a machine that pumps air into the lungs, usually via a tube that goes into the trachea, which is your windpipe. And in order to do that, we need to sedate people so that they're comfortable. So essentially, you get put into a medically induced coma. You may be paralyzed as well, just for safety, to insert the tube. And then the thing that's scary about it is if you're at the point where you need intubation, it may take a week or more often than not more, to be able to be at a point where your lungs have healed well enough that you can come back off of that ventilator. And so what I'm trying to describe is that we're seeing people who are critically ill in a way that I haven't seen in all of residency so far, and it's terrifying. And I think I'm a little luckier than Danielle is, I actually have access to PPE. I haven't had an issue. My hospitals have done a very good job of at least guaranteeing me some of what we need. I have a mask for every shift. We may be using them longer than we ever dreamed we would in the past, but I have them. But nonetheless, you spend the whole shift. I don't wear anything below my elbows anymore. My wedding ring, which I usually wear on my hand, goes on a necklace around my neck. I'm sort of wiping myself down constantly, either the goggles that I'm wearing over top or face shields, using hand sanitizer like crazy, just trying my damnedest not to get sick.
Right. Has that situation with regards to the protective equipment, has that improved? So it sounds like you said it's stabilized and you've implemented different strategies to handle it, but has it improved over time, or has it been where it was 3 weeks ago, for example?
For us, and I think I should make sure that whoever's listening knows that the hospitals I work at have a lot of financial power and a lot of buying power. So we probably have a much better situation than the majority of hospitals, and certainly better than anything in New York. We're just very blessed and lucky in that regard. But not only have we been able to secure new supplies of N95 masks, and I can talk about the different types of masks if that's helpful, but also we've purchased machines that can help sanitize these N95s for reuse. So we're actually, our hospitals are sanitizing N95s for reuse for more than just our own hospitals. We're going to try and start providing reusable N95 masks to the majority of New England. So it's getting a little bit better, I would say.
Epic. Actually, I would love just a quick rundown on what are the main types of masks healthcare professionals are using right now.
There are 2 or 3 big buckets. One is a regular surgical mask, which is a paper mask that you see people wearing around on the streets, and if you watch, I don't know, I haven't seen much Grey's Anatomy, but what I'm imagining they're wearing when they're in the OR is just a little paper mask that clips around your ears. And then an N95 mask has to be fitted, which is why I think it's a little bit silly that so many people have tried to purchase them. I mean, I don't know, it's not silly. They're trying to protect themselves, and I get it, but it has to have a good seal. You need to not have a beard for it to have a good seal, or else it leaks around the side. And basically, it's a filter that goes in front of your face that filters out to a very small particle size, which we think the particle sizes that filter through are actually larger than the virus, but we think the virus is suspended in droplets that do get caught in that filter. So essentially, for the purposes of doing a procedure that causes something called aerosolization, where viral particles get spewed further into the room as opposed to just suspended by larger droplets, which is what happens when you're talking.
Right.
We think that droplet protection, meaning like when they're just talking, doing ordinary things, we think that a surgical mask is probably sufficient. But if you're doing anything that is causing aerosols to be formed, you have to be wearing an N95 to be safe, and everybody in the room does. So that's why we want them so much for healthcare settings, is because most ordinary people are not going to be in situations where and then there's like a little squirt of something you can taste, and then you practice talking, moving your face around, and if you can taste it, then that means that filter or that seal is not good enough for you. So a good example I have is there's a green type of N95 that does fit for me, and our hospitals have secured a source of another type of N95 that, although the seal fits fine on my face, I can taste the substance that they use to test, so that one doesn't work for me.
Right.
If you don't get tested, you don't have any sense of whether or not that mask is any better than a regular surgical mask for your face for that type of mask.
Got it. And the idea is that when you're breathing in, any air that's going into your lungs, into your mouth, into your nose is coming through that filter first. Is that the idea?
Exactly, and not leaking around the sides of the mask.
Right. So, and when you those surgical masks that you were talking about, that you mentioned, a lot of people are those are the kind of the standard ones you see in Grey's Anatomy, and the ones that people are wearing around. How effective are those?
Those are very effective for droplet.
Right.
And more importantly, they're very effective if you're the one producing the droplets. So it spares the people around you, which is why we're now trying to get people to wear them out in public. It's somewhat about protecting you, but it's also protecting others if you happen to be an asymptomatic person with the virus, because it catches them. It doesn't allow it to spew out. But we think it's pretty effective for droplets. It would be entirely ineffective if there were aerosolizing procedures happening.
Got it. Epic. I appreciate that rundown. Okay, so this is a question for both of you. And I love asking this question to people I have on here. is there something about the standard narrative that you're seeing in the media that you think is being missed, or even around the dinner table? Is there something that you think a lot of people are thinking about what's going on that you wish you could kind of just shake everyone in the United States or the world and be like, no, here's actually what the deal is? Is there anything like that kind of, as medical professionals, that's kind of making you a little crazy and you wish people understood?
Danny, you can go first.
Kind of tough. I mean, I think what most people don't know is, and what obviously I can speak to my experience only, is just the impact this is going to have on future medical professionals. I mean, there's 70,000 medical students, and we're all kind of stuck in this awkward limbo of not being allowed into the hospital. So we're not getting the experience that we normally would, and they're going to have to come up with some kind of adaptation. Either we're going to have a huge physician shortage, or we're going to have less experienced physicians going into residency. So I'm not sure how they're going to kind of balance that out.
Right. I think I hadn't even thought of that. So is there anything that your school is telling you now about what they might do? Is it possible they extended the schooling, or have they been hush on strategies on how they'll work around this?
So communication has been fairly limited because they just don't have answers, right? I mean, if nationally they haven't made a decision, it's hard to make a local decision. But they're thinking we might get to come back in June, and currently we're kind of enrolled in an online curriculum that they threw together to try and at least get us some of the learning still while not able to be present. But it's definitely different. Like, all of the national board exams are canceled, so we're supposed to take step 2 at the end of third year, and that's been postponed. I think even residency exams, Dr. Nash, are being canceled or postponed as well.
Yeah, that's true. All sorts of standardized testing are kind of on hold for now.
Got it. Right on. Also, Dr. Nash, same question for you with regards to you think what's missing in the standard narrative, if anything. I don't want to force your hand on this.
I think there's two narratives. I think there's a narrative that comes from science that is pretty consistent with how I think about it, which is, please stay home, please get us PPE if you can. This virus is real, and it kills something like 1% of the people who get infected, which, if a large enough percentage of the United States gets infected, is going to leave maybe up to multiple millions dead. And so far, we've been flattening the curve, so I hope that doesn't happen. And then there's a counter narrative which pretends that this is all overblown and not worth the economic impact. And there's something called, and this is again all my opinion,
totally.
There's something called the Dunning-Kruger effect, which is people are at home and have nothing better to do, and they begin to try to learn about this stuff. And the concept of the Dunning-Kruger effect is that when people have no experience with something, as they start to learn about something a little bit, they become very, very confident in the information they know. And then over time, with more experience, you realize just how much out there is to understand. And ultimately, you're able to truly build expertise in something. But the concept is that the curve has two peaks. The first peak being usually called Mount Stupid, and then over time, the slope of enlightenment. I think what we're seeing is a lot of people who do not truly have expertise in the types of things. And how many people do you know who are virology experts and epidemiologists? Like, this is
totally
things they earn PhDs in. And we've got a lot of people who think that they understand it better than the experts. The real thing to know about this is we all want medicines that work. There's not some conspiracy to get people sick so that pharmacies or farm companies can make more money. That's not a thing that's real, and it's insulting, frankly. And that we all badly want this to get better, and the best way we know how right now is by asking people to stay home. If we start opening up the country again too quickly, what happens is there's going to be a second peak because there's not enough people who are immune to this illness yet. So if we come back to work too soon, we will have a second very bad outbreak that looks a lot like the first.
Right.
And I think people are kidding themselves if they think there won't be economic impacts to that. If they think that the economy is bad now, imagine having to start over. So that's my opinion on all of that.
Totally. I wanted to ask about, and I've talked about this on the show last couple weeks, or rather last week, I think, that it's possible that R naught value or the amount of I don't want to mansplain this to you. You're the fucking doctor. This is just what I read in 2 minutes. Dunning-Kruger effect right now, but it's possible this is more infectious than than we've originally thought, which means more people have it, which means there's more asymptomatic folks out there than we thought, which means the case fatality rate is lower. Is that something that you're skeptical of? Do you think it's because you mentioned that 1% fatality rate? If it turns out a hell of a lot more people have this, that would mean that that denominator is bigger, and that means that case fatality rate is lower. Is that something that what are your thoughts on that? Do you think this is? I mean, it's too early to tell. I'm not saying to give something conclusive, but I'm just curious what your opinion is on that.
Well, there's two features. Danielle, maybe I'll let you talk about the Murray Washington model, but I think one thing to think about is, one, what rate of fatality are you comfortable with? So if we're talking about Dr. Oz levels where he's comfortable with 2 to 3% of people dying from it, we should all just go back to school.
Nice.
I don't think that that's rational.
Right.
I think that R naught is also affected by, so there's two features of it, like how quickly do people get sick? That's one feature of R naught. And then another feature of it is how quickly do people get better? But R naught is variable because the things that we do in society affect it. So R naught will become closer and closer to less than 1 if we social distance. If we stop doing that, then R naught changes. So all the models will, there's a bunch of really good podcasts that I've been listening to about this. And if people are interested in what emergency doctors are saying about it, all of the, there's an education company called EMRAP, EMRAP, that's all available. All their topics about COVID-19 are available for free on YouTube. And it's something I recommend that people listen to see exactly what our educators are telling us as we try and learn about this. And it's interesting. You'll see how it changes from week to week. We're trying to understand this. We're changing event strategies as we learn more. But there's, anyway, that's sort of how I feel about it. I think that it is quite likely. And then the last week's episode talks specifically about that question, Dick.
Got it. Right on. Okay, just a couple more questions, and this is a big topic. I'm curious what you both think of the Apple-Google partnership to track help with contact tracing. And I'm just curious, and we're going to talk more about this actually when you in the next section once we conclude the interview here. Just talk a little bit more about what it actually is. But I'm just curious, just your kind of from what you've read about it. Do you feel it's something that could work? Are you skeptical of it? I'd love to know what you guys think.
So I think. This is how I think about it. I'm not savvy enough with the tech portion of this to know how likely I think it is to work. But I will say this. If we're going to reopen the United States, and if that's what the powers that be have decided, and I'm not going to go too much into my political thoughts on that.
Totally.
I think I've made my healthcare thoughts pretty evident. But if we decide that we're going to go against what experts right now are recommending and we reopen things, then the only way that's going to be at all even remotely safe is if we've got a better way of tracking down contacts. Because it's not a matter of if we open up the economy again and if we make things back to normal as much as possible, there will be a second spike and there will be more people who die. And the only way you mitigate that is if you can track down every single contact of every single positive case that comes up at that point. And if you think that that's possible for 300 million people, I don't know if I agree with that. You might be able to make a sizable dent, but we don't have the same way that we track citizens here the way China has, and they're able to do it for all the bad things that I think about the Chinese. They were able to do that much more effectively than we're going to be able to do it.
Right on. And Danielle, your thoughts?
I mean, I think I texted you about this about 2 weeks ago or a week ago whenever this first kind of came up. And the first thing that popped off in my mind was just like, how will it be used? Like, I understand if it's used simply for kind of contacting who's been exposed, but then there's also the possibility of retroactive penalties, fines for being where you're not supposed to be, and how this data is going to be used in the future if it's all suddenly collected. And I think you reminded me, something I don't like to think about is the government already has all this data, whether or not we want to think about that.
Right. Right on. Sweet. Okay. And as we conclude here, do you guys have any what are your thoughts right now? I had Colin Fedor on last time. I asked him the same question. He works in the government in Massachusetts, and I just asked him what his feeling on what his outlook is. I mean, are you optimistic? Are you pessimistic? Are you neither? Like for me right now, I think I hit that peak 3 weeks ago is when I was most scared. Right now, I think we're kind of now in a position of, okay, we know more about this. We know what we need to do. It's just a question of how much we need to do it. So I'm just curious on on your outlooks on are you feeling better than you were 3 weeks ago? Talk to me.
I think that I'm optimistic, but I'm also resolute because I don't think this is going away anytime soon. And I think when people are thinking on the order of weeks, they're thinking too small. I don't think our lives are going back to normal necessarily until at the earliest the end of 2020. And I think my job's not going to be the same ever again compared to when I started it. I think that I have come to appreciate just how big a deal this is and how much it's directly going to affect me and my family. And I think it's going to stay that way. I did want to make one last plug for it. If you're interested in some more stuff about what it looks like at my job right now, one
Please.
of my colleagues, Clay Dalton, has written a number of posts or written a number of articles in the New Yorker that I think are fantastic representations of what work feels like right now. And additionally, the New York Times has done a couple of exposés on what it looks like with video inside the ERs of New York City. I think that they might be at Elmhurst in that. But New York City is getting rocked hard right now, and I think it might be helpful for people who are not seeing the effects of what this is like right now to get a glimpse on the inside.
Totally. And Danielle?
I actually had a question for Dr. Nash. That's okay?
Go for it.
Do you think this is going to have a lasting push towards telehealth?
Yeah, I think that for all the bad things that are happening from COVID-19, it's also spurring innovation in a way that I don't think we've ever seen before. There's little things like making conferences remote is easier for us. I mean, that's like a nice little thing that we get. But we are now seeing iPads are being rolled into rooms, and people are talking with their doctors on the other side of a safety piece of plexiglass. And then if you take a step back, it is always safer for doctors and nurses and everybody else in the hospital if they're not making contact with people who might be infected with something, whether or not that's COVID-19, whether it's meningitis or pneumonia or whatever else. I think that telehealth is going to become increasingly important, and I think that it'll also be helpful to offload the emergency departments in general, because currently a lot of people come to the ER who don't need to, but if we're able to have them see a doctor,
right,
or see a nurse or see an NP or a PA, we can definitely offload the system. So I think this is going to be a spark under that particular movement.
Thank you.
Epic, right on. And Danielle, do you want to share any thoughts on any on your outlook on whether you're feeling optimistic, pessimistic, anything like that?
I mean, given my student status and just kind of everything being up in the air, kind of a little nervous about it.
Right.
But I'm feeling more optimistic about the number of cases that we have going on in North Carolina, and the death rate we have is currently fairly low. So that's been good.
Right on. Nice. It's always good when fewer people die. Well, let me do while I have you guys here. I appreciate you guys coming on, and I think a lot of people don't think about what the work you guys do until they're actually in the fucking hospital, or they have a loved one with cancer, or they go into the emergency room and they actually fucking need help. I'm always blown away when I go into a hospital. Just fucking, it's magic what we can fucking do with modern medicine, and I appreciate that you guys are fucking both dedicating your lives to this shit, because this is what we need. We got to keep people, alive. We got to keep them healthy, and we fucking need you. So I really appreciate you guys on this front. I think we all do, and now more than ever, obviously. So thank you both for coming on. Really appreciate your time, and hope to have you on in the future.
Thank you so much.
Okay, adios. That was Dr. Chris Nash and Danielle Ryder, an MD candidate. So I'm going to go ahead and switch this, get their beautiful, beautiful faces off here. Thank you so much for joining us. Really appreciate that.